The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics.
Hello, ladies and gentlemen, and welcome back to the FlightBridgeED MDCAST. I'm your host. My name is Mike Lauria. I'm an EM intensive care and EMS physician who also works in critical care transport. And today I have my special guest back again, Dr. Nick George, to help me out here with another topic near and dear to both our hearts, which is airway management and critical care transport. By way of background, Nick did medical school at the University of Maryland, did all of his training, or most of the rest of his training, in residency and EMS fellowship at UPMC in Pittsburgh, and of course the illustrious retrieval and critical care transport fellowship at the University of Wisconsin with our friends up there, and now has a super cool gig working in Australia as a full-time retrievalist. So not many physicians around the world get to work full-time flying around doing critical care transport, but Nick is one of those guys. So welcome back to the show, Nick.
Yeah, good to be back. Thanks for having me. Yeah, still down here in down under, and it's still hot as ever. But yeah, I'm excited to talk about this topic. So thanks for having me, Mike.
No problem. When you first proposed this one, I was like, are we really going to talk about this aspect of airway management? But then when you kept on talking about it, I was like, you know what? Actually, this is a really good idea. I think we need to address this. And so this discussion is basically about crews and airway management. Specifically, does your training, your previous background, whether you're a nurse or a paramedic, really make a difference in terms of airway management? There was some I will go so far as to say inflammatory papers published in the last few years that many of us, including myself and you, Nick, disagreed with, or at least found some substantial. Let's say we found some substantial questions and certain aspects of the methodology that were perhaps not actually representative of the true skill level of our crews. But before we dive into that, let's just take a step back. Let's talk about pre-hospital intubation. And as we all know, in this country, the most common model for critical care transport crews, and by this country, I mean the country that I am physically in right now, the United States, is nurses and paramedics. That's different around the world, right? Where Nick is right now, it's primarily is it actually? I forgot to ask you, Nick. Is it physician paramedic or physician nurse that you're mainly flying?
Yeah, so actually, CareFlight Northern Territory, where I am, is one of the more unique programs in Australia. So we fly physician nurse. The majority of programs in the country do physician paramedic. But yeah, up here we have our nurses, which is another reason this study that we're going to talk about kind of is near and dear to my heart as well.
Yeah. And so in other places around Australia, like you pointed out, my friends down at Sydney HEMS and down in Melbourne, they're flying physician paramedic. And London HEMS, they're flying physician paramedic, and a bunch of other places in Europe have physicians flying too. So, and even some places around the world doing paramedic. So lots of variation in who's doing it. But since it is primarily or mostly nurses and paramedics in this country, we think about that in terms of who is performing the laryngoscopy. And it's certainly one of the more high-risk things that we do in the pre-hospital setting. There have been, I think there's a pretty robust amount of literature that shows that complications can be higher. There's, we do know that we all know intuitively that it is a little bit more challenging working in some of the environments and managing airways in some of the environments outside of the hospital that we work in. And we've traditionally, for better or for worse, come up with a handful of metrics that we try and look at. Some are reported at Gamut and other QA/QI databases, and it's something we always talk about at all the conferences. So let's talk about, Nick, the two key metrics and things that we actually focus on, for better or for worse.
Yeah, exactly. That's a good way of putting it, Mike. And yeah, I agree. When I recommended this topic, it's like, oh gosh, are we going to talk about intubation again? It's like, are we beating a dead horse here? But yeah, I agree. This is really sort of a new development, and actually specifically this topic of the success between different clinicians is important. But yeah, so in order to even talk about success, right? What to see which clinician, a nurse or a paramedic or a physician or whoever is better, we need to start coming from the same concepts, and that is how are we even measuring success? So there are generally two ways in the U.S. Or around the world, really, that we measure endotracheal intubation success, and that's the first pass success and then -1A, right? So first pass success, this is interesting, right? What is a pass, right? So you'll see in the study that we conducted, we have an institutional policy that an attempt or a quote unquote pass is the blade going past the teeth. There have been some studies about whether or not, is there actually that big of a difference between if the blade is still in and you're switching out tubes, for example, can that be considered one pass, that kind of thing. But for us and the purposes of this discussion, right, it is an attempt if the blade goes past the teeth. It's an extra attempt if you have to use any other equipment than the one that you initially placed in there, right? So if you have to switch out endotracheal tubes, or if you have to switch out your blade, right, that's a second attempt. So that's what first pass success is, right? Just, what percentage of your intubations you are able to complete successfully on that first attempt. Now, in recent years, and thanks to our colleagues like Bill Hinckley and plenty of other folks who study this, right, we have appropriately, I think, right, come to this realization that, well, is it the number of attempts that matters, or is it the outcome of those attempts, right? So if you have a couple attempts and you're not having any untoward effects, right, hypoxemia, hypercarbia, hypotension, right, is that actually that important? And that's where they came up with this -1A paradigm, right? So that's definitive airway, sans hypoxia and hypotension on the first attempt, right? So it's sort of this amalgamation of three different metrics, essentially. So that definitive airway without hypotension, 1, hypoxemia, 2, and then if you are getting it on the first attempt. And so those are sort of the two major metrics that we look at. For the purposes of this study, which we can talk about a little bit later, we used first pass success. This is obviously one of the limitations of retrospective research. But yeah, I think our crews should be aware that maybe it's not all about getting it on the first attempt. Maybe it's just doing it with as little, what they call here, hemodynamic and respiratory embarrassment.
I love that. I love the way they put that overseas. I think, and for those listeners who are not, who have not been to some of the conferences and some of the meetings and discussions, there is some critique of the -1A stuff, and I think it's important to recognize that this was huge, because when we started looking at this, as Nick pointed out, it was basically trying to think about, or at least put our minds to, we need to fix these problems and carry the patient through this particular procedure without bad stuff happening to them. And we know that hypoxia and hypotension during intubation or intubation attempts is associated with badness. We're going to talk about that in a little bit in a second. But one of the reasons that this was perhaps that this needs to evolve a little bit further is, and I've seen this with crews, and I've definitely experienced it myself. So if you're measuring hypotension and hypoxia in the minutes before or after the attempt, right? I've definitely had patients that were hypoxic, and I am pre-oxygenating them, and they're coming up, but before they, that 3-minute mark before I intubate them, they're still in the mid 80s. By the time we get up, under positive pressure and doing some other stuff and jaw thrusting, etc., before the intubation attempt, we're at 90 or 92, which is great, but it still counts as potentially a -1A miss. And so I think that it's an imperfect metric, but it is certainly better than just looking at getting plastic between the cords.
Yeah.
So
for sure.
it's not perfect, but it's what we got, and it's better than what we had. And so before we go on to talk a little bit about the history of where this all come from and the evolution of airway management in the field, Nick, what's the big deal? So why do we really care if someone gets hypotensive? So they had an episode of systolic blood pressure of 80, and then we squirted some pressor, we gave them some more fluid, and it came up. So why do we care about some of these things in peri-intubation?
Yeah, that's a really great question, right? And I think we talk a lot of times, especially on podcasts like this, of things that don't have great data behind them, right? But this is actually one of the things that has pretty good data. So why do we care? Well, multiple intubation attempts is going to lead to more complications. And when we have fewer intubation attempts, then it's probably better care. And, it's interesting because you look at some of this research, especially with like head injuries, right? This is where I like to conceptualize this. Like, why does it matter? Well, a single episode of hypoxemia or hypotension in a head injured patient, can increase their mortality up to 3 times. And if they have both, it can increase their mortality up to like 6 times, right? So it's really important. But what's the big deal with this, right? So if you think about it, right, and why did we look specifically at this topic of endotracheal intubation success between clinicians of different licensure, or put it simply, who's better at intubating, paramedics or nurses? So why does this question matter? Well, this question matters because if better intubation success is better care and leads to less complications, and there is potentially one group that does better, well, this actually has really important implications for how we operate our critical care transport teams, right, as medical directors and for procedural deployment, right? And like you said, the most common dyad in the US is flight nurse and flight paramedic. So if one of them is going to be better for some reason, this is something we need to know. And that's why we do research, to answer these questions.
Cool. And I'm so glad you did this study. But before we get into the study specifically, I got to tell you, we probably should go over the history here. And I did want to start out by talking about, and I'm so glad you pointed this out, going back to the 1950s when Peter Safar was working in Baltimore City, and all of the stuff that he did on CPR and airway management, and then of course the illustrious team at Pittsburgh came into the history books and started to rewrite history. I would also give a plug right now. I make no money off this. I have no interest in this whatsoever. But for those of you who have not read the book, definitely check out American Sirens. Fascinating book on the history of pre-hospital medicine. But let's take it from there, Nick. Let's take it from 1961 in Pittsburgh and the history, the birth, I guess, in a certain sense, of pre-hospital airway management.
Yeah, Mike, and first of all, I echo the American Sirens. I make no money off of it either. Phenomenal book. It should be mandatory reading for anyone involved in the pre-hospital realm. But yeah, so, and you and I both sort of rolled our eyes too when we were like, oh man, are we going to talk about intubation again? Well, why do we talk about intubation so much for EMS, right? We do tons of other things. Well, I think one of the reasons we talk about pre-hospital intubation so much is because it is really woven into the fabric of the, beginnings of pre-hospital care. Yeah, so in 1961, right, Peter Saffer, he comes from Baltimore, he moves to Pittsburgh, much like me, right, Maryland to UPMC. Not to say that I'm the young Peter Saffer, but so he moves to Pittsburgh. He starts working in anesthesia critical care, and he realizes that they're doing great work with these cardiac arrest patients in the hospital, but there's definitely a link in the chain of survival that's sort of weak, and that's the pre-hospital care. Because at the time, the majority of pre-hospital care was actually policemen and friends putting people in the back of cars, driving them to the hospital, and the care really wouldn't start until they got to the hospital. This changed for a number of reasons. Actually, Peter Saffer was absolutely instrumental in this change. But specifically, how did endotracheal intubation end up so important in this? Well, unfortunately, Peter's 12-year-old daughter, Elizabeth, in 1966 actually died of an asthma attack in Pittsburgh. And at the time, there really just wasn't, like I said, there wasn't a pre-hospital system. And if you read some of his writings and you read the history of it, this really was one of the impetuses behind him creating this pre-hospital system. So in 1967, he teamed up with this group called Freedom House in the Hill District of Pittsburgh, and they created the first paramedic training program. And it's no surprise then, right? So you have an anesthesia critical care doc whose daughter died of an airway issue, right? Airway management was at the top of his mind. And that became a core component of that first training program. So right off the bat, right? Why do we talk about endotracheal intubation so much in the pre-hospital sphere? Like, obviously it's important, but it's just sort of this thing that's innate to our field. So then comes along his protege, Nancy Caroline, right? And she's the one who wrote the first textbooks for EMS medicine. She was the first pre-hospital physician in earnest. She would go out with these paramedics and, really treat people where they were, as opposed to just bringing them to the hospital. Something that we, now it's like obvious, right? We do this, but that was such a novel concept at the time. And we all really owe her a debt of gratitude for bringing this up. But she probably performed actually the first pre-hospital RSI with John Moon, who actually spoke at NAEMSP a couple of years ago. And so this history here is really important to look at, because this explains why endotracheal intubation is so sort of woven into the fabric. And then you bring it even a step further, right? So, in order to talk about this, this study and endotracheal intubation success between paramedics and nurses, you have to appreciate not just the history of how it came to be in our field, but the history of training, right? So paramedics, right, are, like I just mentioned, they are taught, even the first paramedic training program in 1967, they've been taught to intubate. That is a core paramedic skill. It's something that we all learn in paramedic training. And most paramedics graduate with at least 5 live intubations, right? This is sort of the national standard, some many more. On the flip side, right, and this is an important point for the study, is that nurses are not required to have any formal airway training in their initial nursing training, right? That is just not a part of the national training scheme. And so already at baseline, there is a difference in training here. And I think this is where maybe some of the questions around the appropriateness of who is intubating, and maybe that there potentially could be a difference between the two groups, comes from. But this is why, we have research and we have data, so we don't just have opinions.
That is an excellent point. The reason we have research and we ask these questions is because we, otherwise it would just be a lot of opinions. And you know what they say about opinions?
Yes, I do.
I won't reiterate that, but I think that when we're addressing this, and I want to point this out to the listeners, because when a couple of these studies have come out in the past, there are a lot of people that want to burn them in effigy, and I think that, and some very stern, and that's a kind way to put it, language toward the authors on social media and all sorts of other stuff. We should never be that. I don't think we should ever really completely disregard anything on face value. And it's reasonable to ask these questions, if for no other reason. And not everybody's intentions are along this line, but from my perspective, thinking about it now, it's kind of helpful, because that doesn't necessarily mean that people can't or shouldn't do something, but it may identify areas that we can improve on, or it may identify areas that we can shore up training on, and that's what matters, I think, most to me. But people have been very have a lot of emotions and opinions about some of this stuff. So let's talk about some of those things, that previous literature that's been published in the past that examine this topic.
Yeah, exactly. And I think it's important, Mike, to point out, like you said, that all data is useful in some way, right? So it's good to have the data. It's just all about how we interpret it. But yeah, so I think if you look at the previous literature, I was actually shocked when I started looking into this at how little there is in the way of literature looking at specifically paramedics versus nurses and their intubation success, right? So we had a lot of prehospital data, airway data, looking at first pass success, -1A, all of those metrics, right? But it's interesting, not a lot of the data breaks it down into different success by clinician. And if you look at the data that's looking at success by clinician, there is a fair amount of data, in hospital, right? We know there's those studies of emergency medicine trainees of different, years, PGY years, right? So there's success rates there. There's data looking at emergency medicine physicians versus anesthesia trained physicians in the pre-hospital realm, the differences in success there. There's also data looking at pre-hospital physicians like you and me versus paramedics. So there is a lot of data, but there's not a ton of data looking specifically at this question of nurses versus paramedics in pre-hospital transport. And of the studies, there are really two that stick out, right? So there was a 2020 study that actually didn't look specifically at this, but it was one of the things they reported. This was a study of all pediatric intubations in a single US HEM system. And they note in the study that the first pass success for pediatric intubations between medics and nurses was the same. It was 82.5% and 80.3% medics, nurses, respectively, right? So that's one piece of data, but that study really wasn't powered to look exactly at that question. It was looking at other things. And then comes this study that we mentioned in 2023, published in Air Medical Journal, that looked at 322 intubations in a single US HEM system. And they noted that first pass success was significantly better for paramedics versus nurses, 88 versus 71.1%. And it's important here, right, in just the way we sort of digest this research. And actually, that's why, why do we do podcasts like this? Why do we talk about these things? Because, it's not just a 120 character Twitter post. It's not just a soundbite, right? This is stuff where we sort of talk about it and delve into it in this deeper, meaningful way. And if you look at this study, some things that just automatically jumped out at us, right? So in this program, for better or worse, for right or wrong, we don't assign any sort of value to that, right? Medics were the ones who sort of quote unquote owned the airway. That was just the culture at this program. It's sort of like the culture at a program that I worked at in Wisconsin, right? We had physicians and nurses, right? That's just a different culture. And because medics quote unquote owned the airway, 88.9, so almost 90% of the intubations that were performed by paramedics. So just kind of at face value, it is important to think about how, well, that's different probably, maybe, than a lot of other programs in the United States. And if one group is performing 90% of the intubations, they're probably going to be better at it, right? It stands to reason that that's what would happen. And so that's what led us on to our study.
I think none of us were super surprised when we saw that. Just like you pointed out, if you put the emphasis on it, both, and this is where I think about it in two different components. From a training standpoint and experience standpoint, yeah, if you're doing 9% of the airways, it is plausible to believe that you are more likely to be better with that experience. Also, I think there's something to be said if you think that the medics always did the airway, the medics own the airway. Not only are you getting less repetitions, but when you do, I think there is this psychological, and I see this in other areas in healthcare too, right? The psychological parachute phenomenon where you're like, I'll just let them do it, right? Because you always have this sense that it's someone else's job or someone else can get it for you. And I think ownership, especially in procedural medicine, is really, really important. So I think there might actually be a few more factors at play here as well. But that is all opinion and hypothesis on my part. Let's get down to the meat and potatoes of your study and what you guys found.
Yeah, so obviously there's a link to this study in the show notes, so please do check it out. But this study was a retrospective analysis of all intubations between January 2008 and August of 2023 at our single U.S. HEM service, so at Stat Medevac. It's a regional critical care transport, rotor wing, and ground service based out of Pennsylvania, but they have bases in 4 states in the District of Columbia. Like we mentioned, I'm in Australia now, but I think they're up to like 19 bases now. So a relatively big program, right? And during that time period, crews performed 8,307 intubations. Of those, 94% of those intubations were performed either by a stat medevac paramedic or a nurse. So those 7,812 intubations are the ones we looked at in this study. Just by way of background, right? So the typical patient that we were intubating is pretty much what you would expect, right? This is the patient that I'm sure you're intubating up in the Pacific Northwest and that we're certainly intubating here, right? These are adult male trauma victims. So 91% of these encounters were over 18 years old, 64% of them were male, and over half of them were trauma. One important thing to note about this data set is that we were unable to specifically identify exactly who was in cardiac arrest at the time of intubation. Sometimes people had arrested beforehand or sometime after, but who was sort of like one of those quote unquote like intra-arrest cold tubes, if you will. 94% or almost 94% of the patients had neuromuscular blockade given for intubation. So the assumption is that this number was probably pretty low. All right, so that's sort of the cohort that we were looking at. And so what did we specifically look at? So we actually had talked about this before, right, Mike? We talked about the -1A versus first pass success. Unfortunately, just the limitations of a big data set and retrospective data analysis in your EMS chart, it led to us not being able to look at hypoxemia or hypotension, sort of that -1A phenomenon. So we were able to look at first pass success and actually last pass success. The last pass success is kind of interesting. I'm not sure we coined this term, but I've not seen it before. But essentially what it is the success of that attempt, that is the last attempt that is done on that patient. So if it's successful, obviously they end up with an airway. If not, they end up with a crike or some other, adjunct. And it's important. So the reason we looked at both first pass success and last pass success is when you do have a dyad, like a paramedic and nurse team who both can perform airways, those numbers are not equal, right? So while 53.2% of first attempts were taken by nurses, of the last attempts, that was actually a different number, right? So just the analysis is a little bit different. And then again, if you look at last pass success, is that maybe more indicative of who's potentially better? Because theoretically, if they've already had a couple attempts, that's actually going to be a more difficult airway. So just all things that we were thinking about when we were creating our multivariable model. So like I said, right, we looked at these first attempts. So 53.2% of them were performed by nurses and 46.8% were performed by paramedics. So right off the bat, kind of at face value, we have pretty equal groups here. And it's actually interesting, right? More were performed by nurses. The reason being is that there are actually more nurses in the company than there were paramedics. But on the whole, that is actually indicative of the breakdown, right? There's probably a little more than half of the providers and nurses and a little less than half are paramedics. So that sort of general first pass success, nurses and paramedics were successful in 88.8% and 89.7% of first attempts. And those confidence intervals, they overlap. So that tells us just kind of off the bat that in general, the first pass success was very similar between the two groups. So nurses 88.8, paramedics 89.7, no significant difference when those confidence intervals overlap. But that's sort of an unadjusted analysis, right? So we did a multivariable logistic regression where we wanted to control for a number of important confounders, right? Because, I don't know, Mike, what if all the nurses are doing the intubations on all the patients who have really bloody airways, or all the paramedics are getting all the patients who are in cardiogenic shock, that kind of thing. So you want to control for as many variables as you can. And when we controlled for these variables, we actually found that there still was no significant difference. So the adjusted odds ratio of first pass success between the two groups using paramedics as the referent was 0.90%. With a confidence interval that crosses 1, and last pass success was 1 with a confidence interval that crosses 1. So just right off the bat, that tells us that both sort of in that unadjusted analysis and the adjusted analysis, that there is no significant difference between the two groups. We also completed this exploratory analysis, which was kind of interesting, right? So obviously we controlled in our multivariable logistic regression, we controlled for provider experience, right? So we broke it down into different groups, like less than a year of experience at the company, between 2 and 3, that kind of thing. But what we wanted to look at is, we talked about this earlier in this discussion, that paramedics come into critical care transport oftentimes with airway experience, whereas nurses don't. It's obviously possible that a nurse has come from a different program, or they did something beforehand, or maybe they were a paramedic before they became a nurse. That's all stuff that we couldn't suss out exactly. But just in general, and I don't know, do you agree with this, right? The majority of new hires, kind of straight off, like their first critical care transport job, the paramedics have airway experience and the nurses don't?
I would agree. Most when it is their first critical care transport job, they're coming out of the ICU with the ED. The nurses have essentially no experience, and the paramedics, especially if we were requiring them to have 3 to 5 years experience, generally have a pretty robust airway experience. I think that's fair to say. Yeah,
exactly. And obviously, all programs are going to be a little bit different, but I think that's kind of the general vibe in the country right now. So what we wanted to look at is, okay, so if you take the two groups within the same sort of level of experience, is there any difference? And the reason we wanted to look at this is because it would stand to reason that if a paramedic comes in with airway experience and a nurse doesn't, within that first year, even if there isn't an overall difference between the two groups, within that first year, there might be a little difference, right? I mean, one has more experience than the other. And if we're saying, which I think, we're all kind of thinking with this paper and sort of just our general understanding of prehospital airway management, is that it's experience that matters. It's not really just your credential. So we looked at that. And what we found was that there was a slight difference in the point estimates between the two groups within that first year. So first pass success for nurses within that first year was 74.7%, and first pass success for paramedics was 80.6%. So just on face value, right, those numbers are different, right? One of them is higher than the other, and paramedics performed a little bit better. It's important to note that statistically, they were not statistically different. But again, right, that gets into sort of the whole lies, damned lies, and statistics. So, there is probably a slight difference. It just didn't reach statistical significance. But when you look at it, right, if you look at our table there, that difference progressively disappears. And by 3 years on the job, they're equal again, right? That's the washout period. So just really interesting stuff that got us thinking about, the deployment of this procedure and whether or not it's actually the letters that come after your name that matter, or if it's the experience. And I don't know about you, but to me, it seems that it's probably the experience.
I think so. And this is something we talked about offline, and I'll reiterate right here and right now that I think it is largely about the training, education, and experience that people get. And this wasn't surprising me. I thought this was brilliant, and this is not surprising to a lot of us that follow like the education, technical skills, training, human factors literature, that like there's always going to be a learning and adaptation period, and eventually, even if you have prior experience in one area of some level of expertise, when you're learning novel skills, so if you take like a paramedic and a nurse and they haven't done a skill before, they look very similarly in terms of their skills and progression in terms of successful completion of whatever task or time to completion of whatever task. And then this too, right? If there is a difference in experience beforehand, at some point, as you point out, there's a washout, if you will, or as one group gains that experience with similar education, similar training, and similar experience, has nothing to do with, the letters after their name where they first got their degree. In that case, with that skill, they eventually, it all kind of comes out in the wash, which also underscores another important point that I know you and I had talked about before, which is the quality of the training and the education. I don't think this study was not like looking at that in particular, right? But what I would submit to our audience, what I would hypothesize is that STAT has an amazing training program. A lot of the other programs and some of our guests, whether it's Wisconsin, my friends at Vanderbilt, here at the program I'm at now, you look all across the country, high quality education and training programs, whether you're academic, hospital-based, community-based, can seem to be able to, and I would submit are the reason that we can narrow that gap. And essentially, in the end, after a little bit of experience, exposure, training, and education, they're going to be the same.
Yeah, and that's a great point. And you're right. This study didn't look exactly at the training scheme, if one training scheme is better than another. But I think it's worth mentioning that this study, by the end of, so we did look at all of the years that the study encompassed. By the end of the study period, right, first pass success was well over 90% using this nurse paramedic model. And it's important then, well, how do we get to success like this, and then specifically that equality and success between the two groups? Well, at Stat Medevac, they do 12 live intubations per year, every single clinician. If you don't get 12 in the field, which they often do, then you go to the operating room. And this is all described in the paper as well, and complete live intubations, right? So it's not just on mannequins. And then they do task training at base on shift with those mannequins to sort of get down those micro skills and the crew resource management type skills. And then this includes at least one pediatric intubation, actually in earnest every other year. There's multiple airway training days each year. Whether or not you are one of our clinicians who's had over 5,000 flights and you've been there since the dawn of the program, you're going to be going to that airway training, right? Because like we said, it's about the training, it's about the experience, it's about the whole package. So I was really happy that we were able to get this study out, check it out in pre-hospital emergency care.
Excellent. Maybe, ladies and gentlemen, we'll make sure that the study is posted on the show notes. To hop up on my soapbox for one more minute, I will go so far as to say that this phenomenon applies to a lot of other skills and a lot of other specialties as well. So I'd be willing to bet, and Nick, correct me if you think I'm wrong, there's a lot of stuff that I had to learn when I transitioned into, even as a physician, skills that my nursing and paramedic colleagues were particularly good at and very savvy at. It took me a while to learn. So at my last program, we flew with nitric. Being able to like zero that thing, get the nitric set up, and do all the stuff in terms of like where you put it in line with the Hamilton, I was a disaster at first. Like it took training, education, and time before I could get that together. And there were a lot of other skills as well, right? So it is not for any discrete skill or skill set. It's going to take all of us who are new to whichever program, whether you're a doctor, you're an RT, you're a nurse, you're a paramedic, you're whatever, time to learn that skill. But with good training and education, I cannot prove, but I believe that we can all get there. And in the end, we're all critical care transport specialists doing essentially very, very similar work by and large. So, Nick, thank you so much for sharing this information with us. Great addition to our Airway discussions and compendium. Anything else you'd like to leave the listeners with before we leave?
Yeah, just that, we're all in this field because we want to learn. And just like you said, right, it's all just a lifelong learning journey in medicine. And this paper sort of adds to that. So yeah, thank you very much for having me on. Continue to practice your airway skills, and stay tuned for maybe some future studies where we look at similar groups and maybe other variables like hypoxemia, hypotension, who knows. But yeah, thank you very much, Mike. It was great talking to you.
No problem. Thanks for coming on, Nick. Thank you all for listening. Take care. Have a great day. And of course, fly safe. Talk to you later, everybody. Bye-bye.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.